in the bariatric world, we have different types of weight loss surgeries, and the dilemma that I came across was that a lot of people that I met have told me that they've been denied weight loss surgery because they failed the pre-op psych clearance, because they are being labeled as having a eating disorder when really all they have is a sensory aversion to foods. And if you're a picky eater or if you have allergies, everyone understands that. But if you say that certain food makes you gag, they're going to say that you have an eating disorder. It's what we call the pathology paradigm. It's when the insurance companies need a label in order to be able to bill for the treatment. So let's find a way to put you in a box, put a code on it, and then, you know, I can justify that I treated you today. In my personal situation as an autistic person, in 2007 I went to the bariatric group at NYU in New York City, and I asked to start the process for weight loss surgery. We have a family history I needed to beat, and I was very unhealthy, and 4 children, Crohn's disease. I just couldn't lose the weight, and I needed the help, and that was me at 100 pounds ago. So, and they denied me. They denied me, and they made a referral to an eating disorder clinic. And when I got to the eating disorder clinic, I was a very compliant person. I was like, okay, if you think I need treatment, I'll go fix this, whatever you think it is that's broken, and then let's come back and get the weight loss surgery. So I went. They wanted me to keep a food log, and I wrote down what I was eating, and I wrote, 1 yogurt, half a banana for breakfast, salad with half a grilled chicken for lunch, and then grilled salmon with asparagus for dinner. And I went back the next time and they said, well, you're lying, look what you look like. So I explained that I have a lot of textures that I can't tolerate, mashed potatoes, oatmeal, cottage cheese, all of these issues, and they were like, well, there's no way that you're expelling any food. Fast forward in 2014, in June, it's going to be 2 years now, I moved out of New York City and got approved and had the surgery and did remarkably well. And what's really important is not about inspiring you about bariatrics. What really is important to me is in the Transformative Leadership Program, they teach us how to look at systems or problems on a systemic level and say, okay, so all these big leaders in history came out and they tried to make all these changes. Who am I to make a difference in a specific system? And how do you approach it in a different way? And using my strengths in pattern thinking, I was able to look at ways that other systems were dissolved or changed, and I applied that methodology to this system, and the change has been tremendous. So I'm hoping that you can take my ideas of how I have used it here in this particular case example and apply it in your field so that you can, become advocates and leaders in your area of interest. So what I did was I looked at complexity theory and the transformative critical paradigm, which I'm not going to bore you about, and wanted to completely get rid of the pathology paradigm. And my goal was to impact with change in bariatric attitudes and create social change. The basic idea was I first looked at the facts and I said, okay, so the weight loss surgery eligibility, if you want weight loss surgery, they're going to open your entire body and reroute your plumbing and put it all together again, and then your stomach now is the size of an egg. And you're going to be dealing with that for the rest of your life. The first thing you need to have is a BMI greater than 40. You have to be morbidly obese, not just obese, but morbidly obese. And then you have to have at least 2 comorbid health conditions like diabetes, GERD, which is heartburn, sleep apnea, joint pain, like if they're telling you that your knees are going to need to be replaced in the next 5 years, hypertension. I had 2 of those. I was good to go. I had just hit my BMI at 42. couldn't breathe. You have to have a history of 6 months of previous attempt of weight management. So you have to go for 6 months to a nutritionist in the bariatric group and bring your meal plans and show that you're trying to lose weight, which is a little bit counterintuitive because here you're trying to gain weight so that you qualify with a BMI, but then you come to the office and you need to prove that you can lose 30% of your body weight. And if you can do that, then it proves to them clinically that you actually have the discipline to follow a plan. Very complicated. It turns a lot of people away, especially people who've had a lifelong struggle with weight and they've been weighing and measuring their lettuce their whole lives. The last thing they want is to be judged. Well, you only lost 11 pounds, and it's terrifying. And then finally, you have to have psych clearance. Some of the bariatric groups will have a psychologist on staff. Some of them will refer you to someone within your insurance network, and others will say, just bring a letter of clearance. Here's the form, have the psychologist fill it out. But it's your responsibility to make the appointment. So when the psychologist meets the client, the first thing they do is they do what we call the pre-operative behavioral health assessment. And what they're looking for, according to the American Society for Metabolic and Bariatric Surgery, they're asking that the psychologist do two things. They should identify psychosocial risk factors, look at the family, look at what's going on. Does this person have a support system? When they come home from the hospital, and they're going to have a craving for Chinese food, and they're on a liquid diet for the next 6 weeks, who's there to support them? Who's helping them get to the bathroom and wash when you're not allowed to shower for the first 10 days? So they're looking at all of that stuff, and they're looking at what are the possible familial triggers? Who in your family is going to cause you to eat more food? The other thing is eating attitudes and behaviors. So to accurately distinguish between the maladaptive behaviors and something that's like behaviors that are food related. So are we having an eating disorder, or are we not? Or are we just doing what humans do, emotional eating, or like, I don't have time to prepare, I'll just buy something at the cafeteria, and then you have poor food choices because the options are not what's consistent with your diet. So that's the idea of this assessment. However, when we have a person who has a sensory processing disorder, unfortunately in the DSM-5, the last one that came out now, sensory processing disorder, sensory integration disorder has been removed as part of the diagnostic criteria for autism. So a person who you know in your community may be autistic, we all know they can't tolerate the clothing, touch, and all that stuff, yet it has been removed, and it's no longer a legitimate diagnosis. The only reason they took it out, obviously politics, the only reason they took it out was because the assessments are so individualized, every person's sensitivities are unique to their own experience, so they have no way to standardize the assessment tools. And therefore, if you can't diagnose it, you can't treat it. So insurance will not cover any treatment like occupational therapy or speech therapists working with kids who have oral aversions. They won't cover it because it's not a diagnosis anymore. So there are so many people who actually profess that their sensory issues are their primary disability, and it's just not understood. So when a person comes to a psychologist for pre-op testing and they say, well, I only do what, so many of the sensory aversions that are food related are either the crispy, dry, crunchy people or the soft, mushy people, and you'll almost never see the two. So if you're looking at a chicken tenders for a little kid, there's going to be tremendous aversion because the outside is crispy, the inside is the chicken. Those two textures should not be ever. Don't touch my food in my plate, because it's just too much information for the brain to process simultaneously. So if a person doesn't have any way to be diagnosed anymore for sensory issues, then the psychologist has to put a different label on it. The first thing you're going to get is an eating disorder. However, there are studies about people who have sensory differences, and the top EEG result shows what happens when they call it a disorganized brain. When someone who has a multisensory way of processing things, then information that comes at them, or this is actually an auditory test. So when you're listening to a sound, the typical brain is going to have multiple streams of processing moving alongside together. They're all working together to try to process what they heard. The disorganized brain is going to be all over the place. So you're hearing, you're feeling, you're sensing. All of these senses are wired up now because they're trying to, what the hell was that? And that's why autistic people startle more often, because we're hearing and internalizing everything in a magnified way. You know all the eating disorders. So this is Dr. Nider. He was the one who actually gave me clearance from my, I said, you know what, this is the second time I'm doing this. I'm gonna go there, I'm just gonna be upfront and say, hey, listen, doc, this is my situation. I don't have an eating disorder, but I have significant characteristic traits that are going to lend to strengths as post-op successes. And he said, oh, awesome, fantastic. You're autistic, I got this. Da, 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 da. Boom. In 10 minutes I was out of his office. So I followed up with him not 2 years later, and I said, would you want to, contribute to my capstone project? Tell me what if there's a psychologist, and I gather there's at least one or two in the room here, if there's a clinician who's doing this testing, this assessment, what within the boundaries of their profession are they allowed to, give a person like this clearance? And he said, well, that's very simple. Look at what the criteria is. And he talks about it here.
When examining somebody as a candidate for bariatric surgery, there are a number of things we look at like we would for anyone going through surgery. And the first being, is this person competent to make the decision about having surgery? If in fact we feel that they are, then the next step is to assess them in terms of various elements of their life, including personal, psychological, family, social, medical issues that may be relevant to determining their suitability for surgery. We need to make sure that the person is being appropriately treated. If they have a condition that warrants being followed or treated, then those considerations are taken into account and provided for. When we also look at someone, we take into account not just the things that they may be dealing with, but also some of the assets and strengths that they may bring to the table as well. The fact that you like things very structured, clear-cut, and predictable gave us some reason to make sure that, in fact, as we planned for your surgery, that you had adequate information and appropriate supports for making the decisions that you needed to make. And I think taking advantage of the strengths and resources to your disposal has been very helpful.
He broke down the requirements of the assessment to find room to do what he did. And the first thing in the assessment is the person competent to make this decision? Did I come there on my own accord, or did I come because my parent was telling me, this is what you should say? So I was there myself, I was an adult, and I was ready to do this. Then they look for what he calls existing psychological issues, again, the pathology paradigm. So I didn't wait for him to find it. I came out and I said, here's my story. And if there is a story, if there is a diagnosis or something that needs to be dealt with, they're not supposed to turn you away. They're supposed to actually make a referral so that you can get the necessary interventions that you need, or the treatment, and then come back and continue the assessment and work towards getting psych clearance. In the case of autism, it's actually considered or categorized as a psychological issue because it's in the DSM. And more so, they'll often look at the comorbidity of anxiety and depression that's often found in adults who have an autism diagnosis, and that gives them legitimacy for putting down a psychological issue. So they can technically turn you away because they'll say, hey, you got to deal with your anxiety and your depression before, because we don't want you to turn to food when you're having your flares or your triggers or whatever they call it. The third thing they're looking for is management. How are you going to manage your issues after the surgery? Do you have a system of support? Do you have a service coordinator? Do you have someone who's managing your household? What's life like for you? Do you live in a college dorm and are you forced to go eat in the cafeteria? We need to know all of this before, because we need to map out your success. And finally, number 4, psychological issues. Okay, let's find the assets in your diagnosis. That's actually the requirements for the doctor to look at. And he was like, okay, let's find what your assets are. And in my case, it was I needed everything Excel sheet style. And I needed to know exactly down to the last molecule what I was supposed to eat. And I stuck to it, and it's 2 years out, and I'm still sticking to it. And I probably will never break my patterns, because I'm very in my little box of happy patterning. So he looked at that and he was like, you made that Excel sheet? I'm like, yeah, that's the only way I function. He said, well, site clearance, boom. Because typically people who come into his office are people who have deeply involved issues and relationships with food. They will have cravings for 3 cheeseburgers at a time, have difficulty with not finishing the entire pizza pie. I came there saying, my diet is 4 foods. That's all I eat. And I need the weight loss surgery so that I can get full faster, so that I don't have to be consumed with meal planning all day. I want to be able to eat a yogurt and be good to go for 4 or 5 hours. He was like, you make sense. So here I am. I had a yogurt for breakfast, and what did I have for lunch? I think I had a cheese stick and an avocado. I'm good, I'm happy, I'm full. It's like full pressing full, you know? And I'm satisfied. So they need to look at those assets. That's actually a requirement. And then, of course, the assets, do they interfere or contribute afterwards in management? And if they need to, they should know that it's their role to make referrals, let's say, to the regional center or local autism specialists. They should also know that they can make referrals to developmental disability support agencies, like for speech therapy, occupational therapy, whatever is needed. They should know that that's their last step before they let the person go. Yeah, you know, you gave them clearance, but also give them a plan for afterwards. They should know they could fall back on that. So in looking at my capstone, my idea of, you know, centering it in the bariatric world is obviously my lived experience. I can apply it there. But what I did was, there was this system, this age-old system of, I spoke to so many autistic people who are struggling with their weight, and they can't get it done, and they're dying. They're physically dying. People are morbidly obese. They have sleep apnea. They're falling asleep during the day. They really can't function, and they're not able to navigate the system. And to me, it was very obvious. Let's look at the requirements. I always have to assume that, number one, people in position of power will have an ego. Assume, okay? There are a lot of good people who operate from the goodness of their hearts. But if you assume there's an ego, and you assume that step 2, you need to identify what's in it for them if they come on board. So by identifying with the psychologist who had to assess me that he has an ego, he has to protect his job. And step 2, I had to find out what's in it for him that he gives me clearance. And I found out that he won't have to lose his job because he's sticking to, there's something in the criteria that he can latch on to and justify it for himself. So I'm urging you, when you approach a system that desperately needs intervention, consider looking at ways that will actually make them look better. And they'll be the first ones to jump on the bandwagon because it feeds right into their ego, and it feeds into their need, and it protects them, gives them job security, and they're the heroes. But at the end of the day, you go to sleep at night and you know you fixed a much needed system. So that's my presentation. We're going to be doing questions after Kitsy's presentation. Thank you.
I have a question for both of you. I found both of your presentations and work to be really fascinating. This whole program in schools, I just found out about it yesterday. I'm curious how you plan to apply what you've learned here and with your work in both of your respective areas going forward, either toward if you plan to keep working in sort of the same fields or sort of move in different directions, or I'm just curious to hear from each of you on that.
I'll begin by saying that professionally I give Skype piano lessons to nonverbal and autistic students around the world. And coming here to the master's program gave me an opportunity to bust free from the discipline of music therapy that I was studying and training, and I just wasn't completely aligned to the philosophies of that discipline, and found it so liberating to be able to be my own boss and do my own thing, and see tremendous success if I followed my intuition. So I am kind of unique in the sense where I knew what I wanted. I wanted to be, in private practice, and I wanted to, and I was already doing it when I enrolled in the program. But since going through the the Transformative Leadership Program, I had learned how to celebrate my gifts where before coming to the master's program, it was actually, I was led to believe that somebody please pull the plug on her. Everything that I had to offer was actually destroyed in a traditional university system. I did research as an undergrad, and my department refused to sign off on the IRB approval, so I couldn't actually get it published. And 3 weeks after I got here, well, the excuse they gave me, the department, was undergrads don't do independent research, which is baloney because I would make their university look really, really good. They were really intimidated by what I was doing. So coming here, I was able to be celebrated. Moving along professionally, since I got into the master's program, the requests for what I can do with the training in the program was increasing, and I now present at least once a month. And every time I present, I reach another human being who then goes out in the field and reaches another human being. So it's really exponential. So if you're an advocate at heart and you really want to make a difference, there are ways that your training here can help you make a difference without sitting one-on-one and being a social worker, sitting in an office and billing insurance and seeing one client at a time. You can really take it out there and let your gifts really soar. In the fall, I'm going to start the Ph.D. program in the Integral and Transpersonal Psychology program. And I'm really excited because it will allow me to do non-traditional research to make a contribution to a traditional field. So the school is really exciting because it allows people who think very differently to really, not suffer through the traditional system and be able to contribute in the way that they are born to do.